Hi everyone, my name is Catherine Bauman, and I'm going to be going over a brief presentation about pediatrics and inflammation and going over a couple of common concept exemplars. Here are the presentation's learning outcomes. Basically, by the end of the presentation, the student will be able to provide individualized patient-centered care, describe common inflammation concept exemplars, identify nursing interventions following focus assessment findings, prioritize caregiving based on assessment findings to distinguish between various causes of abdominal pain, and educate patient and caregiver using developmental knowledge. You will get a chance as a learner to complete a brief survey at the completion of this presentation to identify your feelings on whether you have met the presentation's learning outcomes. And now for an overview of the presentation. Abdominal pain is a common complaint of pediatric patients, so we are going to discuss two common exemplars in appendicitis and inflammatory bowel disease, along with another potential and troublesome cause of abdominal pain in sickle cell disease. Okay, now to start with appendicitis. Appendicitis is the inflammation of the variform appendix. It's usually caused by an obstruction. Who is at risk? Any age. It's common though between the ages of 10 and 30. Who is at risk? Just when you meet a patient or even before you come face to face, know the patient populations who are commonly affected with certain illnesses and become familiar with how the different patient populations present with distinctive signs and symptoms. Developmental considerations and patients' ages are common ways to distinguish patient populations, but ethnicity, social background, economic background, they're all ways to assess and possibly give you findings that may assist you in assessing and identifying the priority nursing interventions in any care setting. When we look at assessment data, we're going to note nausea, vomiting, diarrhea, which is more likely in children, possibly constipation, right lower quadrant pain, lethargy, fever, rigid abdomen, decreased to absent bowel sounds, tachycardia, or complaints of increasing abdominal pain. We're going to assess the vital signs pretty frequently. We're going to perform a focused abdominal assessment. You want to auscultate first, then provide light palpation to all four quadrants. Assess for rebound tenderness only if your facility protocol permits. And then we want to perform a cold spa on an age-appropriate pain scale. It is important to be knowledgeable on common diagnostic tests, so know the protocols for your facility, and avoid the mindset of thinking I, as the nurse, won't be ordering the diagnostic test. Instead, aim to grow your nursing knowledge to a competent level in order to anticipate the physician's orders and potential interventions. Be ahead of the game and aim for the best patient outcomes. Besides, some protocols and facilities do allow primary nurses to order initial tests, so aim to be the most knowledgeable you can be. CT scans identify enlarged width thickening of the appendix, which is inflammation, or possibly perforation of the tissue. CPC labs, CRP, urinalysis, those all will lead to showing you that there might be possibly an infection or the patient is dehydrated. It is also important to know certain complications of appendicitis. Perforation is definitely a possibility, peritonitis, and the development of abscesses. Really important to note, notify the provider immediately if the child reports sudden relief of pain or other signs and symptoms. Suspect perforation or rupturing of the appendix wall. And this is an emergency, so you're just going to want to go ahead and prepare the client, prepare the caregiver, and notify the doctor. So since appendicitis is likely to be a medical emergency, which is commonly diagnosed in an emergency room, it is important to know a facility's protocol for initial nursing interventions, including focus assessments and diagnostic procedures. As stated previously, it may be that there are protocols for the initiation of an IV fluids, antibiotics, and pain medications. Be sure to reinforce MD's explanation of surgery, which is often laparoscopic. It's the most common treatment for appendicitis. You want to educate the caregiver on the goal for the surgery to, just have the least possible impaired skin integrity, and for the possibility of temporary drains like JP drain or Penrose. You want to make sure you ask about allergies, discuss signs and symptoms of allergic reaction to report. Oftentimes younger pediatric patients have not been exposed to various antibiotics, so it is important to assess the child following administration of any new medications. If surgery is indicated, the patient must be NPO. There are no exceptions to that. And during patient-parent teaching, remove drinks and food from the bedside and just discuss the importance of preparing for surgical interventions. Reassure the child's caregiver regarding patient's hydration status. Discuss the implementation of IV fluids and their indication for the caregiving of their child. It is also important to note that discharge education begins at admission. Once a care plan and diagnosis is established, education on the patient's entire care experience is important, especially with pediatric patients who are going home with someone who is going to be taking care of them. The child's caregiver is often the one that needs to be most aware of all aspects of the care plan, and also client teaching on caregiving following the potential interventions, including antibiotic therapy exclusively, surgical interventions, etc. They must be discussed. Key education points before surgery are actually to discuss care after surgery, as anxiety and pain may distract caregiver from future teaching points. Discuss the importance of early ambulation following surgery, protocol for resumption of diet as tolerated, possible surgical site or wound care, and the teaching clinical manifestations of and ways to monitor for infection following the surgery. When a pediatric patient presents with abdominal pain, it is important to remember another exemplar of inflammation in inflammatory bowel disease. Although IBD is usually considered a chronic disease, appendicitis is a form of acute IBD. Due to its high prevalence in pediatric patients, this overview will assist in distinguishing its characteristics. Let's look at Crohn's disease. There is known inflammation and ulceration of the GI tract. It can also infect the entire tract, mouth to anus. Malabsorption and malnutrition are common and really important to note in pediatric patients. It commonly presents with 5 loose stools a day, and it's often manifests as right lower quadrant pain. Now let's take a look at ulcerative colitis. Inflammation and edema of the bowels are common symptoms or manifestations rather, and can be throughout the entire colon. There is a high risk of bowel obstruction. There are 15 to 20 loose stools a day, or bloody stools, which is unlike Crohn's disease, and it often presents as left lower quadrant pain. When thinking about who is at risk for IBD, it's often genetic, but environmental factors may contribute to the development as well. UC is known to peak in adolescence and usually presents by age 10 to 20. Diet low in fiber is an increased risk for UC. People who experience stress and frequent infection are also other risk factors to note. As far as assessment data goes, generally patients present with diarrhea, abdominal pain, cramping, which can be frequently in the left lower quadrant, weight loss, fever, abdominal distension, tenderness, and high-pitched bowel sounds. You want to make sure you're assessing vital signs, especially for fever and tachycardia. You want to look for signs and symptoms of shock. You want to perform a focused abdominal assessment. You want to auscultate first, just like with appendicitis, not to disturb the bowel functioning. You want to still perform light palpation to all 4 quadrants. Assess for rebound tenderness if facility protocol permits, just to rule out acute appendicitis. You also want to perform a cold spa with an age-appropriate pain scale. If child complains of pain, example the abdomen, you want to think IBD. As far as diagnostics go, generally there are common assessment findings for each of these disorders in Crohn's and UC, and it often takes direct visualization of and analysis of tissue by colonoscopy in order to distinguish between the 2 main forms of IBD. You want to look at labs, hemoglobin and hematocrit if there's been a lot of bloody stools or risk of bleeding. You want to look at the SED rate, which will be increased in inflammatory processes, white blood cell count, that CRP again, platelets. Occult blood stool sample will help assist in seeing if there's blood in the bowels. Electrolytes are important to check for patients who have had a lot of diarrhea, a lot of vomiting. You want to look at an abdominal x-ray and a CT scan, and then that colonoscopy that we were talking about. One of the main complications of IBD, a chronic complication, is fluid and electrolyte imbalance. You want to also note that bleeding, abscesses, hemorrhoids, shock, obstructions, perforation, and even peritonitis could be complications of IBD. Nursing interventions, you want to maintain fluid and electrolyte balance, monitor intake and output, probably strictly in pediatric patients presenting with these signs and symptoms. Pain management, medications are important. You want to promote rest and comfort measures. Frequent perineal care, assess for impaired skin integrity with frequent stools, diarrhea, that can really take a toll on the skin. Medications, IV fluids, electrolytes, possibly glucose, antiemetics, and antibiotics are commonly indicated to treat acute signs and symptoms. Corticosteroids, anti-inflammatories, immunosuppressants, and antidiarrheal medications are commonly used to treat IBD in pediatric patients and adults. As far as education goes, nutritional counseling is key. Detailed medication education at discharge is really important. Children and their caregivers often need nutritional counseling following a new diagnosis. Both should be educated on the importance of avoiding caffeine and eating foods high in protein and calories, and then low in fiber. Small frequent meals are also encouraged. Dietary supplements may be indicated for children, especially in regards to the developmental stage in which they are diagnosed with IBD or in which they experience clinical manifestations. Also, acute episodes and chronic diarrhea can lead to malnutrition and failure of growth, along with several common medications used to treat IBD in children. Thorough medication education at discharge must be provided by the pediatric RN or clinical educator to encourage parents to assist in everyday care that supports all aspects of the child's health. Healthcare providers may need to be notified of a child's extended illness resulting in the child not taking maintenance medications at home to prevent flare-ups or recurrent symptoms. Nurses must always be aware and knowledgeable of other pathophysiological reasons for abdominal pain in pediatric patients. It can be very difficult to diagnose new problems in pediatric patients due to developmental stages, how their speech is progressing, just their age in general. Appendicitis and IBD can result in peritonitis, which is a similar complication found that can be life-threatening, and it is a form of abdominal inflammation in the peritoneal cavity. Acute diarrhea or gastroenteritis can be infectious. It also may be the presentation that you find in a child that leads to an IBD diagnosis. You want to look out for trauma, possibly from a motor vehicle accident or chronically, potentially due to physical or sexual abuse. Sickle cell disease is also another cause of pain that could manifest in the abdomen but be masked by something else. Always assess for the presence of a child guarding or hunching over the body area that is in pain. The patient may be unable to verbalize the area of their body which is causing pain, but the nurse can assess for guarding during initial assessments. Sometimes the nurse must observe the patient interacting with their caregiver. There's someone that they're comfortable with in order to see guarded movement or behavior. So, sickle cell disease includes disorders due to the presence of abnormal hemoglobin, HbS. It is an autosomal recessive genetic disorder. Who is at risk? The occurrence is more common in people with descendants from countries near the equator. Equatorial countries include Central Africa, the Middle East, Mediterranean, and India. It is important for nurses to note that it is an autosomal recessive disorder, which means that SCD is a lifelong genetic disorder. Nurses may also have the opportunity to educate couples discussing genetic counseling, diagnostic testing, and possibly their offspring's inheritance of the disorder. As far as assessment goes, the presentation or clinical manifestations of SCD may present as early as 6 months of age as infants begin to develop their own hemoglobin. We want to look for pain, irritability, fatigue, shortness of breath, pallor, pale mucous membranes, jaundice, cool extremities, dizziness, and headache. You want to assess vital signs. As far as the pain assessment goes, SCD can result in the vaso-occlusive crisis, which is considered a pain crisis. Signs and symptoms of that can be pain for several days, severe pain to the bones, joints, and abdomen, edema to the joints and distal extremities, the hands and the feet, erythema to the joints, decreased range of motion, vomiting, and fever. You want to perform a cold spot and utilize an age-appropriate pain scale as well. So vaso-occlusive crises must be ruled out when assessing a patient with abdominal pain with a history of sickle cell disease due to the acute nature of the sickling. Obstruction of blood flow can lead to tissue damage, stroke, and death. I also want to talk about newborn screenings, complete blood cell count, electrophoresis, which is a definitive diagnosis. Newborn screenings are often required per state law. We want to talk about some complications of sickle cell disease, the crises, which are vaso-occlusive, aplastic, sequestrian, hyperhemolytic. They can manifest as acute painful episodes, as hypovolemic shock, extreme anemia, but can also just be chronic pain. Acute chest syndrome is also a complication of SCD. Clinical comparison is to pneumonia, and it can be life-threatening. You want to assess for chest, back, abdominal pain, fever, cough, tachypnea, dyspnea, retractions in the child, decreased oxygen saturation. Also, you wouldn't think about it often, but CVA, it can be a sudden event, obviously, that is a result of sickling. Sickled cells block blood flow to the brain, resulting in a CVA. Assess for neurological deficits or changes in the child's behavior and cognitive abilities. You may have to ask the caregiver if they've noticed any subtle changes. It could be that the patient has a history of CVA, and chronic blood transfusions are used to prevent the recurrence of the CVA. As far as nursing interventions go, you want to obtain and maintain patent IV access. You want to assess and implement based on the child's vital signs. And, for example, decreased oxygen saturation means apply oxygen and promote rest. Maintain fluid and electrolyte balance. Monitor their intake and output. Pain management is key. You want to have available medications. You want to promote rest and comfort measures. As far as medications go, you need to know your facility policy for protocol initiation. Administer IV fluids, electrolytes, and pain medications. Antibiotics, antipyretics, and blood transfusions may be indicated. You always, just repetitive, but you always want to ask the caregiver about allergies. Discuss signs and symptoms of allergic reaction, and assess the child following administration of any new medications. Hydroxyurea, PO, is commonly used for daily maintenance of sickle cell disease. Also, for medications in the acute care setting, you want to start with a non-opioid analgesic, then proceed to an opioid if necessary for severe pain. NSAIDs and ketorolac IV are common in the acute care setting as well. For pain management, it may require stronger pain medications, and the patient's caregiver may become worried about the child's addiction to these medications, but just reassure them that addiction is rare and that the medications are only used for severe pain episodes. As far as education goes, you want to teach ways to avoid and notice manifestations of crisis and infection. Inpatient and discharge education, you really want to emphasize the importance of hydration, avoiding constricting clothing, and exposure to cold. Awareness of infection and fever are also key. Give the child specific directions for fluid requirements. Hydration is just cannot be overemphasized to the caregiver and the patient. Both must understand how important that is in preventing the sickle cell crisis. We have reached the end of our presentation, and if y'all will please fill out the survey. It's just 5 quick questions just to see if you feel like you've met the learning outcomes. Also, please see your course schedule for specific readings materials on the exemplars, and just take note of how inflammation and the concepts of inflammation all tie together and show similarities. And lastly, here's a little bit of general information on pediatric caregiving. Just remember to use the nursing process, and remember to provide for pediatric patients in a holistic way. Just a couple of points to remember.